Good evening, all. Today, today I'll be discussing with you approach to focal liver lesions. And as you know, with the more and more ultrasound, CTs, and MRIs that are done, the pickup of incidentalomas are on the rise. And today, the way I'll be approaching is uh, focal liver lesions in patients without underlying chronic liver disease and focal liver lesions in patients with underlying chronic liver disease. So it will be basically a case-based discussion, and uh, any point you want clarification, please feel free to stop me in between and clear doubts before I go forward. So when you talk about focal liver lesions, before going to the imaging, always look at the clinical scenario. Look at whether there are risk factors for or any evidence of underlying chronic liver disease. Does the patient have an underlying chronic liver disease, or are there any risk factors for underlying chronic liver disease, like chronic hepatitis, chronic hepatitis B, or chronic hepatitis C? Does the patient have risk factors for hemochromatosis? Is there any family history of chronic liver disease? Is the patient an alcoholic? Does he have underlying non-alcoholic steatohepatitis, and does he have features of metabolic syndrome? Always look for any evidence of underlying chronic liver disease before you proceed. And always, when you see a patient with an incidentaloma or a focal liver lesion detected on ultrasound or CT, look at the clinical and demographic features of the patient. What is the age of the patient? Is he a male or female? Are there any comorbidities? Are there any risk factors for other malignancies? And always look at systemic signs for infection or malignancy. Is the patient does the patient have features to suggest a pyogenic liver abscess, amoebic liver abscess? Does the patient have history to suggest a hepatitis cyst? Or does the patient have features of malignancy elsewhere? Does he have cough, hemoptysis? Does he have any bleeding PR? Does he have any weight loss, anorexia? Always look for features of malignancy elsewhere. And always take a detailed history and look for any persistent malignancy. Did the patient have a thyroidectomy? Did he have any breast lump? Did he have any hysterectomy? Always look at the past medical history. Patient may not relieve this to you, but if you have to look at this and take a detailed history before you go forward. And always, when you look at the imaging, always review the previous images. Always look at the previous ultrasound images, previous CTs or MRs. Patient might have a female might have an ultrasound done during pregnancy, and that might give you clues to the diagnosis, present diagnosis. And always look at the images. I'll come to the details of the images later. And once you have the images, plan your further blood tests according to the your differential diagnosis, and look for do the tumor markers, alpha fetoprotein, PIVKA2 or TCP, CA99, CEA, CA125, depending on your differential diagnosis. And at times, in spite of all the clinical history, the imaging and blood tests, you may not be able to reach a diagnosis when you need a biopsy and look at a pathological evaluation. But with recent advances in imaging and recent tumor markers, the need for biopsy is coming down. And when you talk about imaging in liver lesions, always do a hepatic protocol, triphasic CT or MR. And I'll come to the details of the triphasic CT in the next slides. And when you do a MR, we can use two types of contrast. There's an extracellular contrast agent. These extracellular contrast agents behave similar to the CT contrast, and they are excreted via the kidneys. And you can have hepatocyte specific conjugate, ribovist or primavist. And these hepatocyte specific contrast agents are taken up by the hepatocytes, and they are partly excreted into the biliary tree. So they have got both biliary excretion as well as renal excretion. And in specific situations, hepatocyte specific contrast agents may give you more information than a extracellular contrast agents. And contrast enhanced ultrasound is coming up in a big way, and many centers have it. And it needs a lot of training, and it's operator dependent. And at times, HCT is done mainly to pick up extrahepatic diseases in patients with hepatic malignancy. You do a PET-CT to see the disease, and especially before a transplant is planned for hepatocellular carcinoma. And nowadays, use of nuclear imaging like technetium RBC scan and technetium sulfocolloid is coming down with more and more advances in the MRI and CT. When you talk about CT, please always, when you evaluate liver lesions, always order a triphasic hepatic protocol CT. Don't just write a CT abdomen because you need a arterial phase. See, you know that the liver blood supply of liver, 80% comes from the portal vein and 20% from the hepatic artery. Whereas when you deal with tumors, the most of the supply is coming from the hepatic artery and not from the portal vein. And so the tumors, most of the tumors light up in the arterial phase. You can see this is the arterial phase. You see the aorta here, it's bright, and you see the liver. Liver is not.
Okay.
The liver is not.
Please mute. Thamizharan, please mute.
In the arterial phase, the liver doesn't take a contrast because liver is 80% of the liver supply is from the portal vein, and you can see that liver nicely uh, taking up the contrast because it's supplied by the hepatic artery. And then you have the portal venous phase, and the portal venous phase, you see that the liver is becoming more and more bright because liver 80% of the liver is supplied by the portal vein, and tumor becomes hypo or avascular tumors. You can see that they are less intense than the surrounding background liver. And in hepatocellular carcinomas, where there's washout, they become hypo compared to the surrounding liver. And this is a delayed phase, that is a equilibrium phase or the venous phase. You can see the kidneys starts taking contrast because they are excreting it, and you can see the hepatic veins and the liver, the hepatic veins become visible. And tumors that retain contrast, like hemangiomas or cholangiocarcinomas, these sorry, these tumors become more and more visible in the venous phase. So tumors that retain contrast, the tumor that has got more scar tissue that retain contrast, that excrete contrast very late, they become more and more visible uh, in the equilibrium phase or the venous phase. And always, when you do a triphasic CT, make sure that there's a 18 gauge cannula. There's a white bore cannula, and you use a power injector. Because if you don't use 18 gauge cannula and power injector, this is what happens. And that's what we commonly see in our clinical practice. See, you you can inject the contrast at various rates. And if you use a power injector and 18 gauge cannula, and always inject for 4 to 6 ml per second. So if you inject 5 ml per second, you can see that the tumor is nicely seen in the arterial phase. Whereas if the injection is slow, the tumor is not picked up in the arterial phase, and you miss the tumor. So always make sure you talk to your radiologist, make sure there's a 18 gauge cannula and a power injector, and always try to use at least a 64 slice CT. And the timing was very important because this is an early arterial phase taken at 18 seconds after injection. You see that the tumor is not picked up the contrast. Whereas when it's at 35 seconds, if you image at late arterial phase, it's at 35 seconds, you can see that the tumor has picked up contrast. And late arterial phase, you see the beginning of enhancement of the portal vein. So you always try to get a late arterial phase because that's when the tumor picks up contrast. Arterial enhancing tumors picks up contrast. And if you don't time it well, you might miss the lesion. And take the portal venous phase, that's around 70 to 90 seconds after the injection. And always take a delayed image, that's around 2 to 5 minutes after the injection, because some tumors enhance during the delayed phase. So tumors like cholangio, you can see a cholangio here, that enhances during the delayed phase. You are not seeing it in the portal venous phase, whereas in delayed phase, you can see that the tumor has started to enhance because of the late enhancement in cholangio. So whenever you take a triphasic CT, always at least a 64 slice CT, a 18 gauge cannula, power injector, and time it well. So so that you get a late arterial phase, a portal venous phase, and a delayed phase. And this is a prerequisite before you uh, do an approach to a focal liver. So coming to the first case, we have a 37-year-old female with history of PCOD, a menstrual irregularities, and the gynecologist does the ultrasound abdomen for her to evaluate her PCOD. And the USG shows a greater fatty liver, and surprisingly, you see a 2.6 into 2.4 centimeter well circumscribed hyperechoic solid lesion in the right lobe of liver. She's otherwise healthy, routine blood chemistry is done, are normal, and there's no persistent liver disease, and there are no risk factors for chronic liver disease. And he's referred to you for evaluation of a liver mass. And you take the history, she was on estrogen pills for menstrual irregularities. There's no family history or personal history of chronic liver disease or liver cancers, and her blood chemistries are normal. So, Dr. Purola, do you want to give a differential here? So
Yes, sir.
you have
Uh,
a 37-year-old female with no underlying chronic liver disease. Incidentally, you see a liver lesion. And what are your thoughts here?
since the age group belongs to second decade and with the on OCP, and she's a menstruating woman, I would like think of hepatocellular adenoma as the first possibility in this case, since it's also a solid lesion.
Mm-hmm. Yeah, good.
And I would also.
Yeah, when in a patient with no underlying chronic liver disease, the most common solid lesions are benign, and it may be a hemangioma, it may be a hepatocellular adenoma, or a focal nodular hyperplasia. And if it's a cystic lesion, the simple cysts are the most common lesions. And this is her ultrasound. Ultrasound, you can see a well-defined hyperechoic lesion here in the right lobe. And this is a MR. Purula, you want to take it, or you want me to explain?
Sir, MR, you explain,
So
sir. I don't
yeah,
know.
so here you see the T1, T2, and here T1 you can see the pre-contrast, the arterial here, the venous and the portal vein and the venous phase. Sorry, this is arterial, this is portal, and this is a venous phase, and this is a hepatocellular, hepatobiliary phase. So in T1, you are seeing a hypoechoic lesion. That lesion, the hyperechoic lesion that you saw in the ultrasound, is appearing hypo compared to the rest of the liver in T1. And T2, you can see that this is a very bright in T2 compared to the surrounding liver. This otherwise called the light bulb sign. And in the arterial phase, you can see that this is the arterial phase. This is a rim enhancement, globular rim enhancement, and that's gradually filling in from the periphery in the portal venous and the uh, delayed phase. So you are seeing a intensely hyper intense lesion in the T2 that is showing peripheral globular enhancement that is filling in a centripetal pattern and gradually filling in the portal venous and the delayed phases. Pirula, do you want to give a diagnosis?
Sir, late filling can be due to hemangiomas.
Yeah, this is a classical of a hemangioma of the liver. So hemangioma of the liver, normally it's a hypo in T1. You have what is called the light bulb sign. That's a intensely hyperintense in the T2. And you have the peripheral globular filling in from in the contrast. Arterial phase, you see the rim enhancement, the globular filling in seen in the portal venous and the delayed phases. So that's classical of a hemangioma of the liver. And hemangiomas are hypo in the hepatobiliary phase in if you use a hepatocyte specific agent. I can't hear you.
I think
Hello,
that
sir.
may be background disturbance here.
Oh, sure, sorry.
There was a background disturbance. So can you repeat the question once again? Dr. Charles?
No, just asking what, was someone asking a question or?
No,
Yeah.
that was a background disturbance. Well,
Okay.
taking that chance, I will ask you one question.
Yeah, sure.
On an ultrasound, if you find a hyperechoic focal lesion in an asymptomatic person, is it not hemangioma? The first thing we have to say, especially students.
Yeah, okay. What Purula said from the history, you have a 13-year-old female who is taking OCPs and you see a 2.6 centimeter lesion. The most common lesion, around 20% would be hemangiomas, and OCPs, the hepatocellular adenomas occur in less than 1%. So most common would be a hemangioma, but with the history of a OCP, that's why he betted for a hepatocellular adenoma.
Charles, what is this like hepatic adenoma? What it is like in the ultrasound scan? Is it hyperechoic?
Hepatocellular adenomas, that depends on what it can be hypo.
It can be hyperechoic, but then there's the question which is raised. When you see a well circumscribed, hyperechoic lesion,
When you see a well-circulated hyperechoic lesion in a patient with no background underlying chronic liver disease, female 30 between 30 to 50, your first diagnosis should be a hemangioma.
Hemangioma. And then when you find a hyperechoic lesion with a posterior shadowing also, then your diagnosis in the ultrasound scan becomes more robust.
If you look carefully, you might see some posterior shadowing here.
Yeah.
So
I think that
ultrasound-wise, the diagnosis should be a hemangioma.
Okay, yeah.
So when you talk about commonest hemangiomas, it can be seen in 20% of autopsy series. It may be these lesions are benign, and 10% may be multiple, and more common in women. And the few atypical hemangiomas, you can see giant hemangiomas that are more than 4 centimeter in size, and giant hemangiomas may have thrombosis or fibrous scars, and that might give a atypical appearance. And another atypical feature would be flash hemangiomas. That's less than 1.5 centimeter, that shows rapid enhancement in the arterial phase and become isoechoic, isoechoic in the portal venous and the venous phase. So these are the two atypical hemangiomas that you see in your clinical practice. But in whenever you are doubt, always take a MR, and T2 will show characteristic the light bulb sign in even in giant hemangiomas and flash hemangiomas. So when you take an MR and look at the T2 images, if you see a characteristic light bulb sign, then that is diagnostic of hemangiomas. So coming to the second case.
I think here, well, to wind up this case, the students may note that the learning point is that, well, the commonest space occupying lesion, focal lesion in the liver is the hemangioma. Mostly the hemangiomas are small hemangiomas, and rarely you can find large hemangioma. Usually in about 2/3 of the patient, ultrasound scan, imaging will be typical, and probably you may not be requiring higher imaging. And when it is atypical or it's large, you need to go for a higher imaging. The higher imaging is mostly a MRI scan, and where there are the typical findings are there, which is Dr. Charles has described. And the students may note that, but you need to know about the MRI scan, the T1 weighted, T2 weighted, the differences, and the common liver lesions, how they behave, you are expected to know, and probably you can go through that. And any questions from the student side? Let me see in the chat box also. I think we'll finish it off and then we'll go for the next case. Is there any size criteria for hemangioma in the ultrasound scan? One question is there.
There's no
suspected hemangioma, which is the first choice, CT or MRI? So I think together you can take up these two questions.
Yeah, there's no size criteria for hemangiomas, and anything more than 4 centimeters is called a giant hemangioma. And a 3 centimeter lesion, typical on ultrasound, you don't need a further imaging. You can, in a patient with no underlying chronic liver disease, no risk factor for chronic liver disease or malignancy, if you have a typical lesion with acoustic shadowing, hypercoagulation, 3 centimeter, then you don't need a further imaging. And ideally, if you want further imaging, it's always better to go for a MR. But only problem with MR is that you and your radiologist should be well versed with the MR. So ideally, if you want to evaluate hypercoagulation, history of hemangioma ultrasound, the ideal further investigation would be a MR.
Okay, so thank you, Charles. That is very clear. And then we go to the second case.
Yeah, so we have a 45-year-old lady with past history of CA breast, T3, N0, M0, underwent mastectomy, and is on follow-up. He presents with right upper quadrant pain. She's otherwise fit and healthy. She has been on tamoxifen for the last 3 years. And this is her ultrasound finding. Jagdish, you want to take it?
Yes, sir. There is a large hyperdense lesion in the liver with the indistinct margins, sir. With peripheral, in Doppler, it's showing peripheral vascularity.
Mm-hmm. Okay.
And
yeah, so you can see a maceration here, and with the lobulated margins, and you can see that the portal vein is indented. This is a portal vein you are seeing, and that is indented by the lesion. And here you can see that it's a portal vein, what you're seeing.
Call it hyperechoic rather, hyperechoic. Okay.
Yeah, hyperechoic lesion. Yeah.
And this is to Jagadish, This is to Jagadish. Yeah, call it hyperechoic in the ultrasound scan. Okay, yeah. Continue, please, Dr. Charles.
Yeah. You can see that the lesion is indenting the portal vein, and you can see the vessels going into the lesion. And this is the CT of the same patient. And Jagdish, you want to comment on the CT?
Yes, sir. This is triple phase CT, sir. In arterial phase, there is a arterial enhancement of mass lesion with irregular border, sir. And there is a washout in both venous and delayed phases also. There is a washout in the.
Okay. So in the plain CT, non-enhanced CT, you're not seeing that lesion. It's almost isoechoic with the surrounding liver. And in the arterial phase, you can see that this is an ill-defined homogeneously arterial enhancing lesion with lobulated margins. And I'm not sure whether you can make out the central scar here. And when it comes to the portal phase, again, it's becoming isoechoic with the liver. And you can see the scar here, center scar here. And in the delayed phases, you are not seeing that lesion. You can't call it a washout. It's becoming isoechoic with the surrounding liver. It's merging with the surrounding liver. And the scar tissue is retaining contrast here. You're not seeing the scar tissue in the delayed phase. So you can see the central scar here, and that central scar is, you're not seeing it here. That's because it's retaining the contrast. So do you want to give a diagnosis with that description?
So with enhanced arterial enhancement with central scar, most likely focal nodular hyperplasia.
Yeah, this most likely to be a focal nodular hyperplasia. So you are seeing a homogeneously enhancing lesion here in the arterial phase with lobulated margins and probably a central scar. You will have to use your imagination. And that's becoming isoechoic in the portal phase and in the delayed phases. And you're not seeing the scar here because the scar is retaining the contrast. So it's most likely a focal nodular hyperplasia. And
Charles, can I make a comment there? The previous slide, please.
Yeah, sure.
Previous slide, please. Previous one. Yeah, I think you may note that what is what is meant by a washout. In the case of washout, you should be seeing it as a hypodense area. Here it is actually an isodense. That is what actually Dr. Charles is highlighting, So that is the difference. In the case of a washout, you will be seeing it as a blackish.
Yes, sir.
Is it not, Dr. Charles?
Yes, sir. Yes, sir.
Yeah.
No
So that
water.
point, that point may be not. So that in fact is the clue here. And then you need to look into the scar. Okay.
Okay, sir. Okay,
Yeah.
sir.
Yeah, that is, yeah. Okay. So thank you, Charles, for highlighting that. Thank you. Yeah.
So FNH incidence is between 2.5 to 8% is lesser than the hemangiomas, usually in females, and it's a benign condition that doesn't require any further follow-up. Once you make a confident diagnosis of FNH, it doesn't need any further follow-up. It doesn't produce any complications of malignancy. And MRI is a most, again, MRI is a very good imaging modality to diagnose FNH. If you see this is a classical FNH, the arterial phase, you see the homogeneous enhancement with the central scar, and venous phase becomes isoechoic with the surrounding liver. And again, this is a delayed phase. And this another FNH, you can see the central scar here. And here you can see that the central scar, nicely see the central scar retaining contrast in the delayed phase. And one of the differentiating features between FNH and hepatocellular adenoma is if we use a hepatospecific contrast agent, you can see that the FNH retains the contrast in the hepatobiliary phase. So what happens in hepatospecific contrast agents like Ivovist or Primovist? These agents are taken up by the functioning hepatocytes, and they are excreted into the biliary tree in the delayed phases around 10 minutes to 20 minutes. So if we have functioning hepatocytes in the tumor, these hepatocytes retain the contrast. If you have normal hepatocytes in the tumor, these hepatocytes retain the contrast and excrete it into the biliary tree. When you image it in the hepatobiliary phase, that's around 20 minutes after the injection of the contrast. So here you can see that this is a hepatocyte hepatobiliary phase, and you can see the contrast, this tumors retaining contrast. So this is one of the differentiating features between FNH and the hepatocellular adenoma. Hepatocellular adenomas appear hypo in the hepatobiliary phase, and whereas FNH appears hypo. And this is a flow chart for FNH. So FNH contrast enhanced imaging, preferably MRI. If it is diagnosed certain, then you don't need any further follow-up. Whereas if the diagnosis is doubtful and lesion less than 3 centimeter, ideal its recommendation is do a contrast enhanced ultrasound, because in lesion less than 3 centimeter, contrast enhanced ultrasound has got a better diagnostic utility than CT. Whereas if the lesion is more than 3 centimeter and diagnosed still in doubt, you can do a biopsy, and biopsy will show a map-like pattern of the glutathione synthesis when you do a immunohistochemistry. And if your diagnosis is confirmed, then you can discharge the patient and no further follow-up is needed. So, suspected FNH and ultrasound, the imaging of choice is MRI. If the diagnosis is certain, then no further follow-up. If the diagnosis is doubt and lesion is less than 3 centimeter, you can do a contrast enhanced ultrasound. The lesion is more than 3 centimeter, then a biopsy will confirm the diagnosis of FNH. So coming to the next case.
I think, yeah, hold on. 1 minute,
Yes,
Dr. Charles, I think, but it's a very important case, why there is a central scar appearance in FNH is a question. So I think I will take up that question also. This is very important, between hepatic adenoma and the FNH, focal nodular hyperplasia. So it's very important, because for the hepatic adenoma, you need to resect. Okay, because it's associated with a lot of complications, including rupture, hemorrhage, and malignant transformation. So that management is you take it out, But in the case of FNH, you will not do it because it is a very benign condition, innocuous condition. There's no need for any resection. So that is it. So you need to make a distinction between these two. Okay, both will be occurring in female. So I think the imaging is very important. If you are confident in the imaging, you can skip a biopsy. Otherwise, you go for a biopsy. Biopsy is very important and FNA will not suffice. That's a second point I would like to highlight. In the case of a hepatic adenoma, a FNA will not actually suffice because there again you find normal looking hepatocytes. What is important is that in hepatic adenoma, there is no biliary epithelium. So that is very important, and that you need to demonstrate with a biopsy. So you need to go for biopsy. And that is the basis of the imaging technique also, which Dr. Charles has in fact suggested. And why there is a scar in the center in the case of an FNH. So that is a question given. Charles, would you like to take it up, why there is a scar? Scar in the case of FNH is a vascular scar. FNH, in fact, is actually a malformation of the tissue, where there is a vascular malformation is also there. What you find is a vascular malformation center. So this scar will be.
Hello?
We lost the connection of Professor Vinay Kumar.
So you're not
taking
audible.
up, this
he's come back.
in the case of adenoma, it is a non-vascular.
Sir, can you repeat what you said, because you are not audible?
Professor Vinay Kumar, we missed your talk for a while. Can you repeat?
I think I lost him again.
I think a phone came. Maybe.
Okay.
Can
Sir,
you?
I cannot hear you.
We heard up to the fact that it is a vascular lesion with a scar, and we couldn't hear what you told afterwards.
Can you hear me right now?
Yeah, yes, sir.
Okay, yeah. I lost it, between the connection lost it. Okay. So I think, so you need to, okay, Scar, your comments, Charles, please.
No, sir, we did not hear you. We just heard you saying that there's a vascular scar at the center.
No, I think, somebody in the chat box, they asked why there is a central scar in the FNS. Yeah. So I was trying to answer that question. Yeah, you can answer that,
Yeah, but, as sir said, it's a vascular abrasion. So there's a vascular abrasion that occurs early in the life, and around that there's a hypertrophy of the normal hepatocytes. That's what occurs in FNH. So you have a central scar with vascularity, and around that you see that the hepatocytes, there's a hyperplasia of the hepatocytes. So you want to add
so
some?
I think no, I think the same thing, because in the case of hepatic adenoma with hemorrhage also you may be able to find a scar-like thing, but that is non-vascular. And so I think if there any other question or any other comment from the faculty, Professor Varghese Thomas?
No, there are no further questions or comments.
Shall we move on to the third case then?
Please move.
Yeah.
Please move on.
Yeah. So Charles, we'll go to the third case.
Yeah. Third case, 34-year-old male who presents with sudden onset of epigastric pain. And he's a bodybuilder, professional bodybuilder with no significant other past medical history. And there's no history of any trauma. On examination at ED, his pain has tachycardia, but there's no abdominal guarding or rebound. And this is the ultrasound finding. Dr. Purola, do you want to give a definition?
Sir, since he's a bodybuilder maybe on anabolic steroids, the ultrasound showing hyperechoic lesions and that bleeding, there is a bleeding into the dilated biliary radicals with dilatation, hemobilia.
Not exactly. You can see two lesions here. You call it heteroechoic. You can see hyperechoic areas and hypoechoic areas surrounding hypoechoic areas. Again, you are seeing a second lesion here, and this lesion looks like it has blood. There's a hematoma here.
Hematoma.
What you're seeing is a hematoma, it's not the bile ducts.
Okay.
And you can see that perihepatic is a large hematoma here.
Hematoma.
So you're seeing a heteroechoic lesion, two heteroechoic lesions, and one of the lesions you're seeing a large, hematomas, and you're seeing perihepatic hematomas. And probably, as you said, the patient is a bodybuilder, maybe on anabolic steroids, likely to be a
Hepatocellular adenomas.
hepatocellular adenomas.
Adenomas.
Adenomas are known to have spontaneous bleeds,
Bleeding.
rupture and spontaneous bleeds. And this is a CT of the same patient, and you can see the lesion with this non-contrast enhanced CT. And here you see the arterial face. You can see the hematoma here and large perihepatic hematoma. You can see the perihepatic hematoma. You see the lesion here and the perihepatic hematoma. I'm sorry for the poor quality of the CT. So most probably patient with the underlying history, 34-year-old, no other comorbidities, bodybuilder. Probably if you take a detailed history, you might get history of anabolic steroids. And with non-underlying chronic liver disease, likely to be a hepatocellular adenoma with bleed. So you want to make any comments there?
Yeah. I think, well, it's a very nice case, because, hepatic adenoma in the male population is very rare. But as you have really pointed out, patient may be on, if the patient is on anabolic steroids, there may be a possibility. So you need to ask that question. And then you need to consider probably other focal liver lesions which can bleed. And maybe in the young man, again, a hepatocellular carcinoma, without the background cirrhotic the changes, maybe another things can be considered because that can also bleed. And then in the case of a hemangioma, again, there may be more probably in the female population, well, that can also bleed, and when it bleeds, the characteristics are very difficult to define and you may have problems. So I think, well, as you suggested, maybe an adenoma, but other differential diagnosis may also need to be considered because during the active hematoma phase, it may be a bit difficult to differentiate.
Thank you, sir. So when you talk about hepatic adenomas, it's a rare entity, occurs in 1 per million women, and there's a 30-fold increase in patients on OCPs. Also, with the recent increase in metabolic syndrome, obesity, and diabetes, there's an increase in hepatocellular adenomas. So hepatocellular adenomas occur in patients who are on females on OCPs and females with metabolic syndrome. And adenomas are also seen with androgen use in men, even though rare. And it can also be seen in patients with glycan storage disease 1A and 3. And the importance of diagnosing underlying glycan storage disease is that patients can be managed with dietary modification. It has been shown that patients with the hepatocellular adenoma and underlying glycan storage disease, you do the dietary modifications. If you make a diagnosis and do the dietary modifications, the hepatocellular adenomas resolve. So here the lesions may be hyper, or heteroechoic, and in CTs you see heterogeneously enhancing lesions in the arterial face, and at times you may see washout, making it very difficult to differentiate it from a hepatocellular carcinoma without a biopsy. And hepatocellular adenomas can contain fat, hemorrhage, or necrosis. So here you can see a lesion. The MR is showing hemorrhage, and here the MR is showing, activated MR is showing fat in the hepatocellular adenoma. So there's a large adenoma, and here's a large adenoma with the bleed, and there's a large adenoma with the fat. And in the arterial enhancing phase in the MR, you can see heterogeneously enhancing lesion, and the portal venous phase, again, you may or may not see a washout. At times, you may see a washout, and making it very difficult to differentiate it from a hepatocellular carcinoma without a biopsy. And in the hepatobiliary phase, when using hepatocyte-specific agent, you see a hypoechoic lesion.
you see a hypercoagulation lesion. So that's the differentiating point with FNH. So FNH retains contrast in hepatobiliary phase, whereas hepatocellular adenoma does not retain contrast in the hepatobiliary phase. So you want to make any comments?
No, I think well covered, you know. I think any comments, Professor Varghese Thomas, or?
I also read that the adenomas can be exophytic and it can be polypoidal, like hanging into the peritoneal cavity. Have you heard any such description? I think in Alton textbook I have heard a description, seen a description like that. It can be exophytic and it may even polypoidal and hang from the surface of the liver like that.
Yeah, adenomas can be pedungulated. It can be pedungulated and hanging into the peritoneal cavity from the surface. So you can have exophytic adenomas, you can have pedungulated adenomas, or adenomas that are deeply in the liver tissue.
And present for the first time with a bleed.
Yeah, exophytic adenomas always can present for the first time with the bleed.
Okay,
So when you see a suspected hepatocellular adenoma, do a contrast enhanced MRI, and a female, always stop the OCP, advise lifestyle, weight loss, and patients with lesion less than 5 centimeter with dietary modification, weight loss, and stopping the OCP, you can see that in 6 months' time, lesions regress or remain stable, and they can be followed up. Whereas in the male, always you need resection. Lesions more than 5 centimeter, or when there's a significant increase in size on repeat scans, then needs a resection because of the increased risk of rupture, bleed, and malignancy. So hepatocellular adenoma in the male, there's increased risk of malignancy and has to be resected. In females, if the lesion is more than 5 centimeter or increasing size, or if they have got complications like rupture or bleed, that needs a resection. Otherwise, lesion less than 5 centimeter can be more followed up by in females. Lesion less than 5 centimeter can be followed up by stopping OCPs and asking them to lose weight and diet and exercise.
There are two questions.
In the chat box, yeah, two questions are there in the chat box. The first question is how to differentiate between hepatocellular cancer and adenoma. And the second question is it risky for biopsying this adenoma? So these are the two questions there. Differential diagnosis, HCC and adenoma.
Okay. Hepatocellular adenomas normally in a MR or a contrast enhanced CT. Classical HCCs, usually you don't see a washout. Only rarely you see a washout. You see arterial enhanced lesions without washout in hepatocellular adenomas. Only when there is a washout, then there's a question of a difference. HCC being a differential diagnosis. And the clinical scenario plays a very important part in diagnosis. Young patients, females on OCP, patients with glycan storage disease with lesions, males on androgen, young males on androgen, such patients is likely to be a hepatocellular adenoma than a hepatocellular carcinoma. And whenever you see a washout, then you need a biopsy to differentiate between a hepatocellular carcinoma and adenoma. And on a biopsy, if you see a stromal invasion, atypical hepatocytes, then that's a hepatocellular carcinoma. Whereas you see monomorphic hepatocytes without biliary epithelium in a hepatocellular adenoma.
So the question is it risky to do biopsy also?
Yeah. Adenomas are vascular lesions, and it's always risky to do a biopsy in a vascular lesion. And incidence of bleed will be around less than 5%. With newer interventional radiology techniques, always a plug biopsy can be done in patients with adenoma, unless they are exophytic, as I said. You should not biopsy exophytic adenoma, pedungulated adenomas. Deeply seated adenomas, you can biopsy, you can do a plug biopsy, but invariably there's a risk of bleed because they are vascular lesions. If you can make a diagnosis with a MR, non-invasive modality, if you can confidently make a diagnosis, then you don't need a biopsy. Otherwise, a biopsy is needed to differentiate it from a hepatocellular carcinoma.
I think my comment is that, often, to differentiate from hepatocellular cancer may not be a big issue there because we are dealing with the larger lesions here. These lesions, when you make out, are often to the size of more than 3 centimeters. And a 3 centimeter lesion, HCC, it will acquire very typical characteristics in the imaging in CT and MRI. So mostly 95% of cases, they will have typical features and may not be a big problem there. And usually the differential diagnosis is with FNH, where if you make the diagnosis, you leave alone. And if you make the diagnosis of adenoma, you need to resect. So I think often the differential diagnosis would come between this FNH and hepatic adenoma and not with hepatocellular cancer. And if you do a liver biopsy, the risk of biopsy in hepatic adenoma, though it is higher than the other benign lesions, is much less compared to hepatocellular carcinoma. If you look at the angiogenesis aspect of the two lesions, is much more in hepatocellular cancer where you don't do liver biopsy. That is the whole thing about it, And it is much less compared to hepatocellular cancer in the case of adenoma, and there probably you can do liver biopsy.
Yeah, probably the only role where hepatospecific agents help to differentiate is between FNH and the hepatocellular adenomas. So if you use a hepatospecific agent, MRI with a hepatospecific agent, in the hepatobiliary phase, FNH would be hyperechoic, whereas FNH will light up, whereas adenomas do not light up. So that will help to differentiate between a FNH and a adenoma in
that's very important. Yeah. Biliary epithelium will be there. Yeah. And another question also probably you need to take up right now is how to differentiate between hemangioma and intrahepatic cholangiocarcinoma. Do you have a case of that later or?
I'll come to that.
Okay. So that we'll do later. Okay. So then probably we can go to the next case.
So case number 4 is 57-year-old. Varghese sir, whenever you want me to stop, please just let me know.
No problem. You please.
So
you finish, then only I'll stop.
It might go on and on. It's already taken.
You have 5 cases now, Charles?
Yeah, but might take some more time, sir. Whenever you want me to stop, please.
No problem. This is a teaching session. They're enjoying it. No problem.
Continue, please.
So it's a 57-year-old female admitted for evaluation of recurrent abdominal pain. Her blood chemistries and OGDs are normal, and an ultrasound abdomen was done that showed it's a ultrasound. Nitish, you want to take it?
Yes, sir. There is a 2 hypoechoic lesion in the liver, sir, with irregular border. And
okay, so see, you're seeing a lesion, anechoic with the multiple septations, thick wall septate, and probably nodules. So you're seeing large lesion here. Ultrasound shows a large lesion.
yes, sir.
You can see the outlines marked here. So it's a large lesion, anechoic with multiple septation, thick wall septate, and probably mural. So do you want to give a differential?
Most likely hydrated, sir.
Any other differential you want to consider? It's a female, 37-year, thick wall cyst, multiseptate cyst with probable nodules. So the one other differential you want to consider is a biliary cyst adenoma. So biliary cyst adenomas, this is a MR of the same patient. You can see the lesion, multiseptate cystic lesion with thick walled septate, and this T2 weighted MR. And you can see the multiple cysts with thick septations and probably nodules here. So when you talk about hepatic cystic neoplasms, it may be a developmental, like a simple cyst, polycystic liver disease or Carolis, or it may be an inflammatory infective cyst like pyogenic liver abscess, amoebic liver abscess, or a hydatid cyst, or a neoplastic like a biliary cyst adenoma or a biliary cystadenocarcinoma or cystic metastasis, or it may be traumatic cyst. So this is a classification of hepatic cyst, or you can easily classify it as a simple cyst or a complex cyst. So simple cysts are anechoic cysts with no septations, thin-walled, well-defined thin-walled, whereas complex cysts are cysts with thick-walled, cysts with thick-walled septations, intramural nodules, multiseptate cysts are complex cysts. And complex cysts may be inflammatory, neoplastic, or neoplastic. So what you are seeing here is a complex cyst. You are seeing a cyst with thick walls, multiseptate cyst with probable mural nodules. So it's likely to be a biliary cystadenoma. Especially biliary cystadenomas occur in middle-aged women, and they have thick wall cysts with mural nodules and thick cyst wall and multiple septations. And they occur in middle-aged women has got a malignant potential, and this is should be a diagnosis should be made, and these are always resected because they can progress to a biliary cystadenocarcinoma. So when you talk about hepatic cyst, it can be simple cyst or a complex cyst, and complex cyst can be neoplastic or inflammatory. And you can see a biliary cystadenoma here. You can see a calcified cyst and another cyst here, likely to be a hydatid cyst, and this is a hydatid cyst. And you've got multiple cysts where in with the renal cyst, you can likely to be a polycystic kidney disease, and rarely you can have cystic metastasis. You can see a cystic lesion here and multiple hypertrophic lesions here, or you can have cystic metastasis. So when you see a complex cyst, one of the differential diagnoses will be a biliary cystadenoma, and always you do a resection. You don't aspirate or biopsy biliary cystadenoma. Always do a complete resection because of the risk of progressing to a cystadenocarcinoma. So you want to make a comment here?
No, I think no. Well, I don't want to make a comment here. And how common this is, in your practice, Charles?
We have seen 3 or 4 cases in the last 5 years which we have resected. It's a rare entity, but it accounts for 5% of non-parasitic cysts in the liver.
Okay. Yeah. And the message is you should not actually aspirate. You have to make a diagnosis of the imaging. Okay.
My question: how often you see hydatitis nowadays? During our training phase and early phase of practice, it was there, but I don't find hydatitis nowadays in north part of Kerala. What about central Kerala and southern Kerala?
Unfortunately, I have not seen one in the last 4 years in my practice. Last 5 years.
Fortunately.
Fortunately or unfortunately.
Also, Vinay Kumar, what about southern Kerala?
No, I think, well, I not be, because when I moved out of this medical college, that volume is not there.
Okay.
that makes a whole difference, Probably well, we need to discuss with Dr. Krishnadas probably.
Okay. But I think overall it has become less, maybe better hygienity and other things.
Okay. Maybe.
Okay.
Shall we move to the next case then?
Yeah, please.
Okay.
Just quickly go through. Sorry.
Charles, we have time. Don't worry. Please take your time. Explain it leisurely because it's a teaching session.
Okay. So when you talk about malignant lesions in non-cirrhotic liver, most common would be metastasis. So most common benign lesion would be hemangioma in a non-cirrhotic liver, and most common malignant lesions would be metastasis. So when you have a 68-year-old male who presents with upper abdominal pain, and you look for past history and you see that there's a history of left hemicolectomy for carcinoma sigmoid colon 5 years back, and this is an ultrasound, and ultrasound shows two hyperechoic lesions. You can see 2 lesions here. hypertrophic lesions in the liver, and you order a CT, and sorry, you order MR, and in MR, so whenever you are dealing with malignant lesions, something I want to highlight here is diffusion weighted images. So in an MR, you can have diffusion weighted images, and diffusion weighted images, when there's a diffusion restriction, it's likely to be a malignant lesion. So in patients with uh, uh, malignancy, metastasis, or hepatocellular carcinoma, you're likely to see a diffusion restriction in the diffusion weighted images. So here this is a MR, the diffusion weighted image, and you can see the hyperechoic lesion here. So there's a diffusion restriction, and that shows that it's likely to be a malignant lesion. And in T2, it's a hyperechoic lesion in T2, and T1, it's a hypodense lesion in T1. And in the arterial phase, you can see a hypoechoic lesion that's just got rim enhancement. So you can see that there's a rim enhancement in the arterial and the portal venous space, and again, uh, there's a hypoechoic lesion in the delayed phase. So these lesions are likely to be metastasis. And the question arises what was asked previously about differentiating between a hemangioma and a metastasis or a cholangiocarcinoma. If I go to the previous slide on hemangiomas, so if you see this lesion here, you can, I'm not sure whether you can see. So this is a hemangioma, and in the arterial phase, you can see peripheral nodular enhancement, discontinuous. This nodular enhancement is discontinuous. It's globular or nodular, and this follows the blood pool. That means the enhancement pattern here is similar to the enhancement pattern in the aorta. So you can see that it's globular or nodular, discontinuous peripheral enhancement that is similar to the aorta. And when it comes to the uh, portal venous phase, again, you see discontinuous nodular centripetal enhancement. And this enhancement pattern follows the same pattern as the aorta. So it follows a blood pool. And in the venous phase, again, centripetal nodular enhancement. It's nodular, discontinuous, and the enhancement pattern is similar to the aorta. So the enhancement pattern in the hemangiomas that follows the blood pool, that follows the same pattern as the aorta in the same phase. So it's the peripheral enhancement is nodular, it's discontinuous, and it follows the same pattern as the aorta, and it has a centripetal enhancement. So it fills from outside to inside. You can see that it fills from outside inside from the uh, arterial phase, the portal venous phase, and the venous phase. Whereas if you come to that metastatic lesion that you're seeing, here in the arterial venous phase, it has got a continuous rim enhancement. It's not globular or uh, nodular like you see in the hemangioma. It's a continuous rim enhancement, and it doesn't have the same pattern as the aorta. It doesn't have the same pattern as the aorta, and there's no centripetal filling in. So that's how you differentiate hemangioma and uh, metastasis with the peripheral enhancement. We'll come to the cholangiocarcinoma in the next slide. So metastatic lesions can be vascular, hypervascular metastasis that's seen in neuroendocrine, thyroid, melanoma, or renal cell carcinoma. It may be hypervascular as seen in colon, in epithelial tumors like colon, lung, breast, or gastric carcinomas. Or it may be cystic metastasis as seen in mucinous primaries of the ovary and colon. So you can have various types of metastasis, and mainly diagnosis is made from the history and uh, the imaging. Minimas, you want to make a comment there?
No. I think you can go ahead. Yeah.
Yeah. So next case.
Explaining very well, I'm enjoying that. Very good.
Yeah. Next case is a 76-year-old male who presents a history of anorexia and weight loss. He's a diabetic on treatment and a chronic smoker. Kurula, you want to have a look
Yes,
at
sir.
the finding and give a diagnosis?
Sir, a large heteroechoic lesion seen with the peripheral vascularity with central necrosis.
Okay. See, you're seeing a heteroechoic lesion here.
Yes, sir.
Very difficult to differentiate it from the surrounding liver.
Yes, sir.
And when you put the Doppler, what are you seeing? What is this? What are this?
The portal veins.
This one?
Portal vein or CBD? Sir, the vascularity, one is CBD, sir.
No, okay. It's a bile ducts.
Bile
They are
duct,
not
bile duct.
contrast inside. So you have a lesion with the distal HBRD. Seeing a heteroechoic lesion with distal HBRD in the ultrasound.
Okay.
So this is a MR. You are seeing a in detubated. You are seeing a hyperechoic lesion.
Yes, sir.
That is hypo in T1. And in the arterial phase, you are seeing a rim enhancement. And in the venous phase, in the portal venous phase, you are seeing that it's more and more getting enhanced in the portal venous phase. And you can see some distal IHBRD. You want to give some diagnosis?
Yes, sir. Since there is a rim enhancement and there is persisting in the delayed phase, I'd like to think of cholangiocarcinoma.
Yeah. So this lesion is likely to be a cholangiocarcinoma. Patient with non-cirrhotic liver. You're seeing a heteroechoic lesion with distal IHBRD, and you can, if you look carefully, you can make some surface retraction here. So you're seeing a lesion with distal IHBRD, surface retraction, and an arterial phase is a peripheral enhancement. Again, unlike the hemangioma, you can see that there's a continuous peripheral enhancement here. It's not nodular or globular like the hemangioma, and it's not similar to the aorta. And in the portal venous phase, the lesion is becoming more and more enhanced. So it's likely to be a intrahepatic cholangiocarcinoma. Vinama, you want to make a comment there?
No, I think, well, you have answered the previous question very well. I think it's demonstrated the difference also very nicely. So I'm just looking at the chat box,
So cholangiocarcinomas can be extrahepatic, it can be hilar or intrahepatic. So you can see intrahepatic cholangiocarcinoma that are mass forming, and you have to differentiate it from metastasis and from hepatocellular carcinoma. So whenever you see a distal biliary dilatation, surface retraction, and you see a rim enhancing lesion with that progressively enhances in the portal venous space, it's likely to be a cholangiocarcinoma.
There is a question,
Yeah.
this question is, what are the resection criteria of the hepatic lesions? That is metastasis in the case of a carcinoma colon. What are the resection criteria of the hepatic lesions in the case of a carcinoma colon?
So can I look it up and get back to you?
No, I think that's the mostly a theory question here. No, I think probably if you probably you want to make the diagnosis in diagnostic aspect, but the number, size, etc. is a different thing, that is beyond the discussion today. But then you make the diagnosis. If that is what you mean, well, if imaging is enough, as in the case of hepatocellular carcinoma, or would you like to go for a pathological diagnosis, in which case, if it is going to be FNA or whether it's going to be biopsy. So I think that much we can take up right now. Yes, no.
If you have a past history of, if you have a colon cancer and you see liver lesion, and liver lesions are typical of metastasis on CT/MR, and you have got an elevated CA, then you don't need further biopsies to make a diagnosis. So if you have got a
Also the FNA is not a bad option also here because unlike in the case of HCC, it's very diagnostic, FNA is very diagnostic here, and then it is not that risky. And then probably the only point, in fact, is needle tracking, which you are, when you are actually confronted with the next thing of resection, etc. So you can make an imaging diagnosis based upon the situation. FNA is not a bad idea also.
I can't remember doing FNA in the last 5 years because nowadays we are moved away from FNAs and more to biopsies.
Yeah, for the metastasis also,
Yeah.
You want to do the resection, before the resection, would you like to cleanse the diagnosis, both FNA or would the imaging is enough for you to make for the resection,
In the clinical setting of a colon cancer on follow-up ultrasounds, you see a rising CA, you see a metastatic, you see a lesion, hypercoagulation, rim enhancement, then you don't need a new lesion arising in the liver that's hypercoic with rim enhancements and rising CA. You don't need a further biopsy to make a diagnosis. And solitary lesions, you probably go ahead and resect it depending on the site of the lesion. Easily resectable peripheral lesions, then you go ahead and.
I think, but it is, the imaging is enough. Well, that is what is actually being said, but I don't really know that, whether I thought, an FNA is required, so that's what I thought, but then I may be corrected.
Most of the patients will have serial imaging right from the initial diagnosis and a new lesion that is typical of a metastasis and rising CA. I don't think you need a imaging. It can be refer and get back to you.
Okay. Yeah. So I think it will be informed to you, So I think well, please check up and then inform.
Yeah, I'll do that. I'll do that.
Two further questions. What is a capsular retraction with the reference to this cholangiocarcinoma? And then with the background of cirrhosis, how to differentiate HCC with hepatic cholangiocarcinoma?
Good question. Cholangiocarcinomas are sclerotic lesions. Sclerotic means there are a lot of fibrous tissue in that, and whenever there is sclerosis, there's the peripheral cholangiocarcinomas tend to cause retraction of the liver capsule. So you can see the retractions of the liver capsule because of the sclerosis of the cholangiocarcinomas. These are fibrotic lesions, and fibrosis causes contraction of the liver capsule into the liver. So that is thought to be one of the diagnostic features of a cholangiocarcinoma. But rarely it can be seen in other fibrotic lesions also. And I'll come to the cholangiocarcinoma and in the differentiating liver and between HCC and cholangiocarcinoma. I'll come to you in a subsequent piece.
Okay. I will go to the next case then. Okay.
So we have seen what are the most common cases in most common lesions that occur in a non-cirrhotic liver. The most common benign lesions would be hemangiomas, FNH, and hepatocellular adenomas. And hemangiomas are the most common, and that should be thought of first when you see a incidental in a patient, otherwise asymptomatic patient without underlying chronic liver disease. And if you're suspecting a malignancy, then the most common malignancy in a non-cirrhotic liver would be metastasis, and other tumors would be rare in a non-cirrhotic liver. So coming to focal lesions in patients with underlying chronic liver disease, whenever you see a lesion that is more than 2 centimeters in a patient with underlying chronic liver disease, always think of hepatocellular carcinoma unless otherwise proved. So that's a dictum you should always remember in your practice. Large lesion, 3 centimeter lesions, you get a CT report as dysplastic nodule, or always you follow it up with a repeat imaging or a repeat imaging to rule out a hepatocellular carcinoma. Lesions more than 2 centimeter is always HCC unless otherwise proved. So coming to our fifth case is a 56-year-old male who's got a known case of national cirrhosis, child day on follow-up, 6-monthly follow-up. And ultrasound shows a chronic liver disease, portal hypertension, patent portal vein, no ascites. And you see a new onset 2.8 centimeter uh, well-defined heteroechoic lesion in the right lobe of liver, and his head is 3.6 nanogram per ml. And this is ultrasound finding. Jagdish, you want to make a comment?
Yes, sir. There is a heteroechoic lesion in the liver, sir.
Pardon?
There is a heteroechoic lesion with
3.6 centimeter heteroechoic lesion, well-defined margin.
well-defined, and yes, sir.
Yeah. So you don't have portal vein is patent. There's no ascites. And this is a CT. You want to comment on this?
Yes, sir. There is a arterial enhancement.
Arterial phase. This is a portal phase and the delayed phase.
Yes, sir. There is a arterial enhancement during the arterial phase with washout in portal and delayed phases, sir.
So you're seeing an arterial enhancing lesion with that's becoming hypo to the surrounding liver in the portal venous and the delayed phase. So that's
Yes,
a washout. So this is so to call it washout, it has to be hypo to the surrounding liver. Unless it's
Yes,
hypo to surrounding liver, you cannot call it a washout.
Hypo. Yeah.
Okay. So what would be a diagnosis?
Sir, it's hepatocellular carcinoma, sir.
Hepatocellular carcinoma. So most likely it's a hepatocellular carcinoma. So when you talk about nodular lesions in an underlying chronic liver disease, it may be a regenerating nodule, it may be a dysplastic nodule, a low-grade dysplastic nodule or high grade dysplastic nodule, a well-differentiated hepatocellular carcinoma or moderately differentiated hepatocellular carcinoma. And how do you differentiate? Normally in normal liver, you got the portal tracts with the where you have got the portal vein, the hepatic artery, and the bile ducts. So regenerating nodules will have the portal vein, hepatic artery, and the bile duct. They have the portal tracts. Low-grade dysplastic nodules also will have the portal tracts, and as it progresses from a high-grade dysplastic nodule to the hepatocellular carcinoma, the portal tracts disappear and you get unpaired arteries. And that's the reason why you get hyperenhancement in the arterial phase. So in the hepatocellular carcinoma, you get hyperenhancement in the arterial phase because they are supplied by the unpaired arteries. And there's no portal vein. So when it comes to the portal venous phase, there's no blood supply to the hepatocellular artery compared to the surrounding liver. So that becomes hypoattenuated compared to the surrounding liver. That's why you get the washout. So as we progress from the regenerating nodule to the dysplastic nodule to the hepatocellular carcinoma, HCCs are supplied by the unpaired arteries and you get hyperenhancement. And since there's no portal vein there, there's a venous washout in the venous phase. And when you describe nodules in the cirrhotic liver, you use what is called the Lirac system. And Lirac system, what we look at is one is a arterial enhancement where there's a hyperenhancement, hypoenhancement, or isoenhancement. And then you look at the diameter of the tumor, what is the size of the tumor, and then you look at three features of the hepatocellular carcinoma. One is the washout, second is capsule, I'll come to that later, and where there's a threshold growth. When you do serial CTs or MRs, where there's a growth in the size of the lesion. And depending on this, you can classify it into Lirad 3, 4, or 5 lesion. Lirad 5 are classical of hepatocellular carcinoma. Lirad 4 are indeterminate. You can either follow them up with serial CTs or MRs, depending on the size of the lesion, or you can do a biopsy to confirm the diagnosis. And Lirad 3s are unlikely to be hepatocellular carcinoma. So when you talk about nodules in the cirrhotic liver, it may be a regenerative nodule. Usually regenerative nodules are less than 2 centimeters in size, and they don't enhance with contrast, and they contain lot of iron, lot of siderin, hemosiderin, and hence they are hypo on T2. When T2 images of MRI And the regenerative nodules are hypo because they contain a lot of iron. And on contrast, they don't show any contrast enhancement. So a lesion, T2 lesion, a hypo dense lesion on T2 imaging that do not show any contrast enhancement is likely to be a regenerative nodule. Coming to dysplastic nodules, again, these lesions are likely to be less than 2 centimeter, and this may be hypo or hyper in T1 weighted images. It's a T1 weighted images. You can see a hyperintense dysplastic nodule. In T2 images, if they are low grade dysplasia, low grade dysplastic nodules are likely to contain iron, hence they appear hypo in T2 weighted images. If they are hyper in T2 weighted images, they're likely to be high grade dysplastic nodules. And in arterial phase, as I said, if they may or may not have uh, hyper enhancement in arterial phase, but they don't have washout in the portal or delayed phases. So dysplastic nodules are iso or hyper in the T1. Low grade dysplastic nodules are hypo in T2, or they may be iso or hyper in high grade dysplastic nodules are iso or hyper in T2 weighted images. And they might show arterial enhancement, but they never show venous washout in portal venous or delayed phases. And coming to hepatocellular carcinoma, as you saw in the previous case, there's a CT, there's a lesion here, and that is not well seen in the non-contrast CT. Whereas in the arterial phase, you can see that there's a heterogeneous enhancement in the arterial phase, and there's washout in the venous phase. And along with washout, we can clearly make out a capsule. So presence of a capsule is almost a diagnostic of a hepatocellular carcinoma. That differentiates it from a high-grade dysplastic nodule from a hepatocellular carcinoma. And other features that help to differentiate from a hepatocellular carcinoma is presence of hemorrhage into the tumor. So in the non-contrast image, you can see hyperdense lesion within the tumor here, suggesting there's a hemorrhage in the tumor. And in contrast, there's arterial hyperenhancement, venous washout, and there's a bleed into the tumor. And bleed into the tumor is seen in patients with hepatocellular carcinoma. So whenever you see a hemorrhage into the tumor, a tumor with arterial hyperenhancement and venous washout, likely to be hepatocellular carcinoma. And whenever you see a tumor with a capsule in the delayed phase, it's likely to be hepatocellular carcinoma. And other feature is a presence of fat in the tumor. You see fat in the tumor. This is a MR, T1 weighted MR. You see that, this is a T1 weighted MR, and you see that there's a fat in the tumor. So presence of fat in the tumor is a arterial phase, arterial enhancing lesion with venous washout. You can see the capsule here, and in the T1 weighted images, you can see that there's a fat in the tumor. So presence of the fat in the tumor, bleed in the tumor, well-defined capsule, these are features of hepatocellular carcinoma. When you see all these features in a nodule in the cirrhotic liver, the patient likely to have hepatocellular carcinoma. And this is another feature of hepatocellular carcinoma that's called the mosaic pattern. You can see that this in the venous washout phase, there's necrotic areas in between, and there's a lot of fibrosis in between, and it gives a mosaic pattern. So mosaic pattern, if you see a mosaic pattern, then that's likely to be a hepatocellular carcinoma. And in diffuse infiltrating lesions like this, you see that the portal vein is infiltrated with the tumor thrombus. And here there's a tumor thrombus. In the arterial phase, you can see that the thrombus is enhancing. And in the venous phase, there's a washout. So diffuse infiltrating lesions, and you see a thrombus that is continuous with the lesion, then that's likely to be a tumor thrombus and likely to be hepatocellular carcinoma. So presence of the classical feature is a arterial hyperenhancing lesion with a venous washout, and associated features would be presence of a capsule, presence of fat in the lesion, presence of a bleed into the tumor. Then the other rare tumors would be with large tumors with mosaic pattern and diffuse infiltrating lesions, where you see a portal vein thrombus, and that is enhancing in the arterial phase and washing out in the venous phase. So all these are features of hepatocellular carcinoma. And about 10% of patients with hepatocellular carcinoma will be hypovascular. You don't see a arterial enhancement in the arterial phase, but you see only a venous washout. So 10% of patients are hypovascular and you see only a washout. In such patients, you follow them up with AFP, PIVCA, or a repeat imaging. And if they show high AFP or PIVCA or repeat imaging shows changing size of lesion, you can take them as hepatocellular carcinoma. And another entity that you commonly see, that you rarely see, is called the hepatocolangiocarcinoma, where in cirrhotic liver you have got arterial enhancing lesion that progressively enhances in the venous phase. So these lesions have got features of both hepatocellular carcinoma and cholangiocarcinoma. And unless you do a biopsy, you may not be able to make a diagnosis. So these lesions show features of both hepatocellular and cholangiocarcinoma. And that's very rare tumors, less than 1% of the liver tumors in cirrhotic livers. So that's cholangiocarcinomas. Vinamasa, you want to make any comments?
I think, well, you have explained everything very nicely, Charles, but Professor Varghese Thomas in the chat box has asked to say something more about these LIRARs, So I think I'll make one or two statements about that, LIRARs is actually expanded as liver imaging reporting and data system. So that is what it is expanded as. Well, this is actually to find out, the diagnosis, the accuracy of diagnosis of hepatocellular carcinoma in cirrhosis liver by imaging. We know that, universally what is accepted for the diagnosis of hepatocellular carcinoma in cirrhosis is radiology. Without cirrhosis, it is not radiology. But in cirrhosis, with cirrhosis, it is radiology. So there should be a common understanding, reporting, and diagnosis of the same, especially when you refer the patient and also take up the patient for research purposes. So I think that these criteria are taken into consideration to classify into across type 1, 2, 3, 4, and 5. Type 1, in fact, is essentially benign, and 5 essentially is typical of HCC, and 3 will be intermediate. And the 2 and 4 is actually coming in between in the benign direction and the malignant direction. Though that is in fact LIRARs. So this is a typical reporting pattern. So when we refer the patients for imaging, they will come with the diagnosis of, say, a focal lesion in the background of cirrhosis liver, with all the description, and say that, LIRARs 5. That is actually typical. LIRARs 1, in fact, it is not, it is definitely benign. So that is how it is actually interpreted as. So that is about LIRARs, And then we'll go to the chat box, how to differentiate between bland thrombus and tumor thrombus.
Yeah. So see, any thrombus that is continuous with a lesion is tumor thrombus unless otherwise proved. So you got a 2 centimeter, 3 centimeter lesion in the periphery, and you see that there's a thrombus that is continuous with the lesion. So 1 second, my laptop charger is charged. So any thrombus, any portal vein thrombus that is continuous with the tumor is tumor thrombus. The second point would be an expansive thrombus, a thrombus that is expanding the portal vein. A thrombus more than 22 millimeter that's expanding the portal vein. That's a tumor thrombus. And tumor thrombus most often will show arterial hyperenhancement similar to that of the tumor in arterial phase. And you see a washout in the venous phase. So any thrombus that is contiguous with a lesion, any thrombus that is expansile in a setting of tumor, any thrombus that is expansile that shows arterial enhancement and venous washout, that is a tumor thrombus. So,
I think,
a lesion, a thrombus that is continuous with the lesion, even if it doesn't show venous arterial enhancement, venous washout, it has to be taken as a tumor thrombus, unless otherwise proved.
I think that's very clear right now. So how to differentiate between regenerative nodule and dysplastic nodule? It in fact is well answered. In MRI, I think all the pictures are actually shown. Dysplastic nodules should undergo resection or loco-regional therapy as they are pre-malignant. So I think
as of now, there's no recommendation to intervene in a patient with dysplastic nodules. If you know that patient has got dysplastic nodule, and if you're 100% sure there's no reason to intervene, you have to follow them up. High-grade dysplastic nodule is very difficult to differentiate from a hepatocellular carcinoma. But if you see features like tumor within tumor, nodule within nodule, if you see that it's hypo in hepatospecific agents, if you see that it's hyper in T2, hypo in hepatospecific agent, you see a capsule, you see a nodule within nodule, then these lesions are likely to have malignancy within. And such lesions, you might intervene. Otherwise, dysplastic nodule does no indication to intervene.
And there is another question, what do we mean by threshold growth?
20% growth in the diameter of the tumor. So you have a CT now that shows a 2 centimeter lesion, and 3 months later you repeat CT shows 2.4 centimeter. That is threshold growth.
So I think there is no further questions in the chat box, And do you have another case, Dr. Charles?
No, that's the last case, and that's a flow diagram from the American College of Gastroenterology. And the only point I want to highlight is that whenever you deal with the focal lesion of liver, always go and sit with your radiologist, discuss within the clinical history what you're looking for, tell him what you're looking for, and always plan the CT prior before. Don't just send the patient saying a CT abdomen and expect the radiologist to give a correct diagnosis. So always you have to sit down with the radiologist, tell him what you are expecting and what is to be looked for. And then sit with him and read the CT. Always go down to your radiology console, see the CT with them. Then most of the time you have a diagnosis.
So I think, well, anybody would like to have a question right now? In which case, probably we can.
Regarding the question on the resection of liver mets in colon cancer, I think apart from resection, I think lung also people have started resecting, but other areas I think are not resectable. So I think patient will have to get thoroughly evaluated for metastasis in other parts of the body, and that is number one. Number two, the basic liver functions. Third, the total volume of the tumor which is to be resected, and if it exceeds more than 2/3 of the liver, I think we won't be able to remove the entire thing. And the criteria is actually if a lesion is resectable and if 1/3 of the liver is left behind for at least 2 healthy segments, it can be attempted provided there are no other contraindications. Then in some cases, a partial resection of the metastasis may be done, and then it may be downstaged by loco-regional therapy or chemotherapy, and the surgeon may attempt subsequently. A margin of 1 centimeter is mandatorily required, and if the margin is less than 1 centimeter, there is a high chance of recurrence of the disease in the liver. So these are the various criteria for the resection of metastasis.
Thank you very much for the prompt updating. A few more questions have appeared in the chat box. I think we can very quickly go through that also. Features of fibrolamellar HCC in the imaging. What is the sclerotic HCC? How to differentiate between highlighted cyst and biliary cyst adenoma by ultrasound scan, and imaging of choice by hydatid cyst. So I think first for HCC and then we'll go to hydatid.
Yeah, fibrolamellar HCC usually seen in younger patients, females, and these are well-defined lesions with uh, capsules, and they follow almost the same pattern of enhancement classical HCC. And sclerotic HCC is the HCC that shows fibrosis, a lot of extensive fibrosis, and again, sclerotic HCCs may not show the classical imaging pattern of the classical hepatocellular carcinomas. They might retain contrast. They may not show the classical washout. They might retain contrast and behave similar to a hepatochondroplasia carcinoma or endopathologia carcinomas. And you might need a biopsy there to differentiate it.
And about hydatid cyst, imaging of choice.
Sir, you want to add something?
Pardon? No, yeah, I think fibrolamellar.
Sir,
Fibrolamellar HCC, I think it has got a capsule and then it also has got a scar, something like that of an FNH, a scar is one of the conditions with the scar is that, so, and that's all. I think cirrhotic HCC, well, to differentiate radiologically, I don't know whether there's anything in the radiology, I don't know. How to differentiate between hydatid cyst and biliary cyst adenoma by ultrasound scan?
No, hydatid cyst, you see whenever you see small excess daughter cyst, calcification, and what is called the water lily sign, where you see the endocyst that is dissected from the wall and floating in the cyst. Then you think of a hydatid cyst, and there'll be the history of travel, and you do a hydatid serology that will be positive. That's when you think of a hydatid cyst. And biliary cyst adenomas, classically you have thick wall cysts with thick septations and intramural nodules, and the wall might show peripheral enhancement on contrast. So, that's how you differentiate a biliary cyst adenoma. Young female with 30 to 50 thick wall cysts with thick wall septations, intramural nodules, and peripheral vascular enhancement on contrast. That's likely to be a biliary cyst adenoma. Whereas if you see with a background history, you see a lesion, and then you see a cystic lesion with the small excess daughter cyst. You see calcification on the wall. You see the water lily sign. Then that is history of a hydatid cyst. And you have the WHO classification of CT findings in hydatid cyst. And hydatid cyst.
In ultrasound scan, you can find the trilayered cyst, with that floating pattern, and if you see the movement, once you see it, you'll not actually forget that. But the problem is you may not be able to see the movement in all the patients. But once you see it, it's very classical. Any comments on the molecular biology of HCC and the importance of the PET scan in HCC?
Okay. Yeah. From the clinical practice, you see that some HCCs behave well. The patient go on, even though we say that TACE is not curative. Some of these patients whom we do TACE, we see that they live for 5 years, 6 years, 7 years. Whereas some HCCs are very aggressive, and some recur even after transplant. Those within criteria recur after transplant. So HCC behave differently, and some of the clinical indicators that we use to predict the biological behavior. One is the level of alpha fetoprotein. High alpha fetoprotein, more than 400 or more than 1,000, likely to be very aggressive HCC. And second would be PET positive lesions. So before a transplant, we always do a PET. And PET in a CT, in a HCC is used to look for extrahepatic disease. Also, if the patient is positive for FDG PET, then those lesions are likely to be very aggressive lesions. And so these are the clinical parameters that we look for when you want to differentiate between a aggressive HCCs that are likely to recur post-transplant. So high AFPs, PET positive lesions are likely to be aggressive HCCs that are likely to recur after transplant and likely to have a aggressive course. And molecular biology, two things. One, when you look at molecular biology, one is to look at the clinical behavior of the tumor, and second is to look at how they respond to various targeted therapies and immunotherapies. So you look at whether they respond to TK inhibitors or whether they respond to the targeted immunotherapies by doing a molecular analysis.
And PET, the role of PET in HCC.
Yeah, PET, as I already said, hepatocellular carcinoma, the role of PET is you can use dual PET to make a diagnosis. Dual PET means you can use choline and two tracers. One is choline and second is FDG. So that increases the yield of PET in hepatocellular carcinoma, because the hepatocellular carcinoma usually the choline, the FDG uptake is seen in less than 50%. And whenever you use two tracers, then the yield is higher, about 80 to 90%. And patients who are positive for FDG PET, they are likely to have very aggressive hepatocellular carcinomas and likely to recur after transplant. Also, PET is used to look for extrahepatic disease whenever you are planning a curative treatment.
However, none of the professional bodies have actually endorsed the utility of PET scan in the diagnosis also.
Yeah. So whenever you take a patient for transplant, there are two options to look for extrahepatic disease. One is to do a PET or do a bone scan plus CT. So some centers do bone scan and CT, some centers do the PET. And PET can be a FDG PET or a acetylcholine PET.
Okay, so I think there's a role for the PET scan when you contemplate upon the transplantation process. So I think, shall we wind up now?
Yeah, I think we have covered all the questions. And
yeah. So I think, thank you, Charles. You have conducted the session excellently well. What I like most, in fact, is you're very sharp, to the point, and attention to the details. So that's why you are my pet. You're my prize candidate. I'm very proud of you.